Hello, my name is Mark Haber. I'm a clinical associate professor and my interest is in shoulders only, so shoulder orthopedics, www.so.com.au, and my email is markdhaber@gmail.com. I'd like to thank you for listening to this presentation. I hope you find it useful. And what this presentation is all about is shoulder stiffness. If you have any questions, you can always forward it to markdhaber@gmail.com, or you can go to my website and leave a message through there, www.so.com.au. Well, something about myself. I'm anatomically very specific. I only do shoulders and therefore somewhat geographic spread out. I do clinics at Sydney in the CBD, George Street, Macquarie University Hospital, in Wollongong and Campbelltown. I operate also out of 4 different areas: East Sydney Private Hospital, Macquarie University Hospital, 3 hospitals in Wollongong, and Hurstville Private Hospital. And the thing about consulting is because I'm anatomically very specific, just doing shoulders, and geographically I do 4 clinics, all clinics, including the Sydney City, CBD, Macquarie, Wollongong, and Campbelltown. I run what's called a one-stop shoulder clinic. And in all those 4 clinics, I always have an ultrasound machine and almost always work with a sonographer with a special interest in shoulders, so we can do a check ultrasound on any patient and also perform an ultrasound guided cortisone injection when indicated. So the case that we base this talk on is AC, who's a 52-year-old diabetic lady with gradual onset of pain and progressive loss of shoulder motion. The question is this a frozen shoulder? So we will explore what information would you collect through history, taking an examination in this case. What is your differential diagnosis? What is the management plan? When would you refer it to a specialist like myself? And how would you manage this situation if you found no red flags versus what are the red flags and when would you do a referral? So we'll talk a lot about the red flags in the frozen shoulder patient. So we have 2 learning outcomes. Number 1 learning outcomes, understanding clear updated definition of a true frozen shoulder, also known as primary capsulitis, and understanding predisposing factors to shoulder stiffness such as diabetes, thyroid disease, autoimmune, and previous shoulder trauma or surgery as potential risk factors for a secondary capsulitis. It's not a primary capsulitis. Knowledge of these factors will help manage these conditions. Our second learning goal is understanding the assessment and management of shoulder stiffness to diagnose a primary versus a secondary shoulder stiffness through comprehensive history, physical examination, diagnostic imaging modalities, including ultrasound, X-ray ultrasound, and MRI when this is indicated. And we'll talk about the principles of management. The important thing is not putting the cart before the horse. That is to do the things in the wrong order. What we want to do is put the horse before the cart. And in that sense, what I'm talking about is making a diagnosis before we initiate management. For example, I saw a patient who had 12 months of physiotherapy because of shoulder stiffness with no benefit, and only after 12 months with an X-ray done to find out the patient had arthritis, so it wasn't a frozen shoulder. So I'll stress the importance of a diagnosis before we make a management plan. Now the big question is, what do we mean by a frozen shoulder? It's like speaking different languages. What I mean by a frozen shoulder, what you think of as a frozen shoulder, what the physio refers to as a frozen shoulder may be entirely different. So defining it is very important, and the International Society, ISOCOS, has the recommendations on how to define the terms. For example, stiff shoulder is to describe a patient who presents with restricted range of motion regardless of the etiology, and that is either a primary or secondary causes. When they refer to a frozen shoulder, is to be used exclusively for idiopathic stiff shoulder. Secondary stiff shoulder is for a stiff shoulder with a known etiology. Adhesive capsulitis, the recommend is not to be used because there aren't actually any adhesions. And they state that capsulitis can be either primary or of secondary causes. So therefore, a frozen shoulder is equal to a primary capsulitis. Interesting history. Ernest Codman coined the term frozen shoulder in 1934. He described this condition as difficult to define, difficult to treat, and difficult to explain from the point of view of pathology. So it's amazing how things have largely not changed since 1934, nearly a century. And in 1945, Julius Nerviza redefined the condition as an adhesive capsulitis underlying the inflammation and fibrotic changes observed in the capsule or adjacent bursa. So we do agree that it's a capsulitis, we just don't use the term adhesive anymore. Now, what Nerviza talked about with regard to frozen shoulders is that using that term for a stiff and painful shoulder for any reason is a rubbish bin diagnosis because it has no meaning. So these days we classify shoulder stiffness into either primary stiffness, when we can call it a frozen shoulder, or secondary stiffness, then we therefore call it a secondary capsulitis. Now, a primary stiffness or true frozen shoulder or primary capsulitis, the underlying etiology cannot be identified. So we need to search for, is there an explanation? And if everything comes out clear and there's no obvious etiology, only then can we call it a primary stiffness, frozen shoulder, or primary capsulitis. So the current definition recommendation is a condition of uncertain cause characterized by significant restriction of both active and passive range of motion, which occurs in the absence of a known intrinsic shoulder disorder. Now, what they mean by an absence of a known intrinsic shoulder disorder is having no significant findings in the history which could explain it. Investigations are essentially normal, and to explain the stiffness and pain, and so therefore it is an idiopathic stiff shoulder. As opposed to a secondary capsulitis, when the underlying etiology or an associated condition can be identified, for example, a type 1 diabetes. Now, the secondary capsulitis can be further subdivided into three categories. It can be due to a systemic disorder, as we've talked about, like diabetes mellitus, but also thyroid disease and many other systemic disorders. Or it can be due to an extrinsic cause, an identifiable abnormality remote to the shoulder itself. For example, a humeral shaft fracture, breast cancer surgery, or anything remote from the shoulder that causes the stiffness. Or it can be intrinsic. This is further subdivided into four categories of intrinsic abnormalities of the shoulder joint. It can be rotator cuff tendonitis, rotator cuff tears, biceps tendonitis or calcific tendonitis. But the thing about rotator cuff tears, that is the most challenging, especially if it's a partial thickness rotator cuff tear, because making a precise diagnosis is one of the hardest aspects if it is indeed a partial thickness rotator cuff tear. The accuracy of ultrasound versus MRI remains controversial. One study concluding that both methods underestimated rotator cuff tear size by about at least 33% and concluded that no method was able to determine the size of a partial thickness rotator cuff tear, and that many studies have demonstrated partial thickness rotator cuff tears are often missed. And this has become an extremely interesting topic, and in fact I was asked to present at the Malaysian Arthroscopy Association in 2022, and I presented some data on partial thickness tears and rotator cuff tears and in workers' comp patients at the ISACOS Congress in 2023 in Boston. So it's a very interesting subject at the moment. So the thing about intrinsic abnormalities of the shoulder joint causing stiffness, one of the most common ones which we see very much is postoperative rotator cuff repairs. Now, true frozen shoulders, as we said, that is primary capsulitis, is idiopathic stiff shoulder. So examples of not true frozen shoulders are stiffness in the shoulder after, for example, rotator cuff repair surgery or any trauma. That's not a frozen shoulder. It's often referred to as one, but as we've tried to explain, it's a secondary capsulitis. As example, the natural history is very different. After rotator cuff repair surgery, you get sudden onset of pain after the surgery, and you get rapid development of restricted movement, that is stiffness. So typically, you develop quite significant pain and restricted range of motion, and this can take up to 12 months to resolve. So a very different natural history of a primary or true frozen shoulder. So postoperative rotator cuff stiffness is quite a unique entity, and I've given it the nickname PORCS, as in porks. Now, a true frozen shoulder versus a secondary stiff shoulder, differentiating between the two main types of shoulder stiffness, can be very difficult with frozen shoulders or primary capsulitis with no underlying cause, or secondary stiffness with an underlying cause. Making the difference is critical in the ongoing management. A secondary capsulitis has an underlying issue, as we've talked about. So, if the natural history is different, therefore so is the treatment. So, a stiff shoulder or a primary versus secondary has a different natural history, different treatment. If the secondary due to systemic disorders, extrinsic disorders, or intrinsic disorders, also changes the natural history and the management. And of course, if it's intrinsic, that also changes the ongoing management. So in a true frozen shoulder, that is primary capsulitis, the primary pathology is within the capsule of the shoulder joint. The capsule is not torn, but becomes inflamed and stiff and restricts glenohumeral motion, which can be severely restricted, and therefore most of the motion comes from the scapula, not the glenohumeral joint. Now, interesting thing about the epidemiology of frozen shoulders, it's reported to have a prevalence of somewhere between 2 to 5 or even up to 10%. So it's actually an amazingly common condition. The other thing is it's more than twice as common in women more than men. This is the quoted figure, but I think it's actually far more common in women more than men. Menopause is thought to be a cause of frozen shoulder due to the age that women develop it, but it is thought that age is the main factor. It's nothing to do with menopause. Now, the interesting thing about age and sex is that males are at greater risk for a longer recovery and greater disability. They have more pain and more stiffness, a bit like, as we laugh about, the man flu. Also, the age and sex of the sex are different. The average age of onset in women is 52 years old and is 55-year-old in men. So the most common and most classic one is a spontaneous onset of pain inexplicably in a woman in her 50s. Now, frozen shoulder, the cause remains poorly understood despite many attempts to explore the underlying cause. And it's a bit like being struck with lightning. It's sometimes inexplicable. But more recently, some information has become available that does help us understand this condition. Hereditary conditions such as diabetes, autoimmune thyroid disease, and inflammatory arthritis do have a genetic link, which makes a person more likely to develop primary capsulitis frozen shoulder if they develop these conditions. So it seems to be come down to the genes. And the risk of the other shoulder is also interesting. 15% of patients, it may affect both shoulders. It can be simultaneous, which is actually very rare, or sequentially, which is usually occurs within 5 years of disease onset. And interestingly, the recurrence in the same shoulder is extremely unusual. One can almost say it almost never occurs. Now, what's the pathophysiology of a true frozen shoulder? This was outlined in 2018, where inflammation and fibrosis of the joint capsule was noted to be mediated by cytokinins, growth factors, MMPs, and immune cells. And it affects primarily the capsule of the shoulder joint. So the primary pathology is in the capsule, where the normal, very flexible capsule is infiltrated with myofibroblasts and fibroblasts and inflammatory cells, which contracts the capsule. So the inflammation with fibrosis, it's often described as a mini cytokine storm, where the inflammation strikes the capsule. And it can be quite incredible when you do an arthroscopy. It's like somebody's painted the entire capsule and ligaments, which are normally white, bright, bright red. So it's almost like there's a perceived injury to the shoulder capsule, where mediators are sent through to the body, and the body responds by sending inflammatory cells into the capsule. Platelets, white cells, and fibroblasts all infiltrate the capsule. I use the analogy, it's almost like somebody's sent a message to deliver concrete, which gets poured into the capsule, making it thickened and inelastic and stiff. And there's a domino effect, a chain reaction, where one event triggers a series of related events. In a primary capsulized and frozen shoulder, we're not exactly sure what the trigger is. In a secondary capsulitis, the trigger can be identified. But once the domino effect starts, the dominoes keep on falling until they run out. And this is a very unpredictable time frame. So how is a true frozen shoulder or primary capsulitis diagnosed? First of all, there's the history, physical examination, and other causes eliminated based on investigations. And so all about a thought process called pattern recognition. This approach is particularly useful in cases where conditions exhibit a very characteristic pattern. It's the old expression, if it looks like a duck, swims like a duck, and quacks like a duck, it probably is a duck. So what do we notice on history? First of all, the age. Glenohumeral joint instability occurs in young people and almost always under the age of 40. Rotator cuff disease generally develops over the age of 60, and it gets more common as you get older, as does osteoarthritis, which tends to occur in even older people. But capsulitis has a very different pattern, classically occurs in the 50s. The history, the mechanism is also very helpful. Instability, there's often trauma, rotator cuff syndrome, repetitive lifting or age, osteoarthritis, often goes off arthritis and other parts of the body with age, but frozen shoulder, it's very different. There's a gradual, inexplicable onset in the absence of any history of injury. It's very gradual onset and very subtle. And again, the classic story is a woman in her 50s inexplicably developing gradual onset of pain, which gradually gets worse and associated with stiffness. So the age is a huge clue. There's a very few conditions of the shoulder joint that peak in people in their 50s. As we talked about, instabilities in the young, arthritis in the older, and rotator cuff tends to be after people in their 50s, rarely occurs in people in their 50s. So these are the red flags. If it doesn't look like a duck. Examples include bilateral disease, under the age of 45, over the age of 65, unusual presentation, or the question is there a trigger? Because if there is, it's not a duck. It's a red flag, needs further investigation. Now, how about examination of the shoulder joint with capsulitis? Traditionally, in orthopedics, musculoskeletal, we always talk about the concept of look, feel, move, and perform relevant clinical tests. However, in the shoulder joint, the skin covers the joint, the muscles are under the skin, which cover the joint, the tendons cover the joint, and thus the joint is deep to all these structures. So there's nothing usually with a capsulitis you can see or feel that will help you in the diagnosis. The key help is moving. So you only very simply have 4 simple movements. Forward elevation, external rotation, the arm by the side, internal rotation, and they're the main 3, and the hint is a globally reduced range of motion, but especially including external rotation. Think of capsulitis, because typical things like rotator cuff disease, external rotation with your arm by your side is usually quite comfortable. So, as we said with examination, can't see much looking, can't feel much feeling. Movement, the hint is a global restricted in range of motion, and clinical tests really aren't very helpful. So how do we diagnose in terms of imaging? The thing about imaging is, especially with MRIs, can be very costly, can be very painful if you need to do arthrograms, very inconvenient. People are very claustrophobic with MRIs, and incredibly unreliable for diagnosing a frozen shoulder. So of all the investigations available to us, including X-ray, ultrasound, CTs and MRIs, for it to be a true capsulitis, they've all got to be normal. MRI arthrogram may be abnormal, but very, very rarely indicated. So it's what we call a diagnosis by exclusion, where all other possible diagnoses have to be ruled out. So a thorough assessment of the patient's symptoms and medical history, rule out other conditions that could explain the symptoms, and then the remaining diagnosis. If no other plausible diagnosis remains, you arrive at the diagnosis by exclusion. Now, the limitations of a diagnosis by exclusion is you rely very heavily on investigations which could explain the symptoms, but these can be wrong. Now, let's go, for example, investigations X-ray. X-ray in adhesive capsulitis is a diagnosis by exclusion. It should be 100% normal, but it's worth doing if we're thinking about osteoarthritis. This is an example of a perfectly normal X-ray. And this is an example of very subtle signs of early glenohumeral joint arthritis, where you get these little spurs, which are called goat's beards, which are a hint that arthritis is developing. If you see those little spurs, it's not a primary capsulitis, it's secondary capsulitis to arthritis. What about ultrasound? They don't really have a role in instability. They don't really have a role in osteoarthritis because they're plain X-ray diagnosis. But what they do help enormously is separate adhesive capsulitis from rotator cuff tears and syndrome. But be careful about the report, because almost every ultrasound is reported as a subacromial bursitis. Not everybody's got a subacromial bursitis, but it seems to be present in every single report. This is an example of an ultrasound. On your left-hand side, we see this is the bone of the humeral head, and this is the junction between the deltoid and the rotator cuff. And this is an example of a very small partial thickness tear, which can be very, very subtle. Now, this is an example in contrast of a full thickness tear, the bone, the junction between them above the deltoid, below the rotator cuff. That blue is the rotator cuff. And this is the tear, which has a more significant retraction and is more obvious. So the left is a partial thickness tear, the right is a full thickness tear. Now, what about the role of MRI? Again, it's a diagnosis by exclusion. In capsulitis, there are subtle changes. MRI of capsulitis shows small amounts of fusion, especially around the biceps tendon. Now this is inflammatory fluid leaking out of the shoulder joint. There's no primary problem of the biceps tendon. It's just inflammatory fluid, which we also see within the capsule. And again, it's another example of it around the tendons, but not due to the tendons. So it's another example of a larger fusion within the shoulder joint and around the biceps tendon in a true capsulitis. But an MRI can exclude other causes. And this is an example of a partial thickness tear on an MRI. It can be very, very subtle, can be easily missed. So an ultrasound, this is an example of a medium full thickness tear of a supraspinatus, which the sonographer reported as 12 by 7 millimeters. It's a full thickness tear, complete detachment of the rotator cuff. But in the MRI, it's reported as a partial thickness tear of 9 millimeters, involving only 50% of the tendon. So we can see there's a very different picture, and the MRI very much underestimates, compared to a good ultrasound, the size of the tear. So when it comes to diagnosis of a frozen versus a partial thickness tear, the relationship between partial thickness tears and a true frozen shoulder is a complex issue. I would suggest that many cases of partial thickness tears are misdiagnosed as a frozen shoulder, as small partial thickness tears are often not visualized on the MRI or an ultrasound. But partial thickness tear and frozen shoulder both cause stiffness. We see that a lot in the workers' comp patients. So frozen shoulder versus partial thickness tear. One study concludes that both ultrasound and MRI underestimates rotator cuff tear size by about 30%. And I think that's universally true of MRI, but an ultrasound can be more accurate and it's done by a skilled sonographer. And they determined that no method was able to determine the size of partial thickness tears. And I totally agree with that regarding MRIs, but as I said, a good skilled sonographer is able to determine partial thickness tears a lot better. But unfortunately, small tears are very often missed, and they're put down as a frozen shoulder when it's actually a small tear. Now, when we talk about the natural history of frozen shoulders, there's a traditional arbitrary division into 4 stages, which have been talked about a lot. So when you get the pain gradually developing over time and the movement gradually deteriorating over time and slowly recovering. Then there's the pre-adhesive stage where you just have a bit of pain and we don't know what's going on. But then there's what's called the freezing phase, where the pain gets worse and the range of motion deteriorates. Then there's what's called the frozen phase, when the pain is severe, the movement is deteriorated significantly, and it stays the same. Very frustrating for the patients. And then they go through the thawing phase, when the pain gradually deteriorates and the movement gradually recovers. Now the time frame is incredibly variable. Classically, pre-adhesive and freezing can take up to 9 months to complete. The frozen phase, up to 20 months. And the thawing phase, up to 26 months. So very long and very variable. The average or the mean is 30 months, but I'll stress it's very, very variable and very unpredictable. And indeed, a long-term outcome of a frozen shoulder study by Hand in 2008, he looked at patients at 4.5 years. And what he showed that 40% of the patient had ongoing symptoms. Only 60% were normal or even near normal. And 5% at that stage had severe symptoms. So Wong did a study on the natural history of frozen shoulder, did a systematic review, and noted there was a low quality evidence of long-standing assumptions about frozen shoulders, and he concluded that the theory of recovery phase leading to complete resolution without treatment for frozen shoulder is unfounded. The authors of this study suggests correcting professional and public misconceptions about frozen shoulders may reduce delays in people seeking treatment that demonstrates moderate to strong evidence for improvement in pain, range of motion, and function. And they conclude that this leads to a recommendation that references to the theory that frozen shoulder progresses through stiffness to recovery phase leading to full resolution without supervised treatment should be discontinued. So the elephant in the room is that those with the most severe symptoms at condition onset had the worst long-term outcome. So how do we manage this condition? There's counseling, which is most important, physiotherapy, cortisone injections, and occasionally arthroscopic release. So in terms of counseling, once a diagnosis has been made, you can then start planning management and explaining to patient the natural history, but stressing the importance that it is extremely unpredictable. Gentle thawing of the frozen shoulder in one study stated a prospective study of supervised neglect versus intense physical therapy. They demonstrate that intense physical therapy regime that includes active stretching and exercises that supersedes the pain threshold caused much more severe pain. And what they showed is that supervised neglect over a 24-month period versus intense physical therapy demonstrated that the patients with supervised neglect had approximately 90% in normal and near normal at 24 months, whereas only 63% for those who had intensive physiotherapy, even at 24 months. So they concluded that supervised neglect yields better outcome than intense physical therapy and stretching in patients with a true frozen shoulder. So the message here is that it is a slow and steady wins the race. The physiotherapy can be helpful, but has to be very, very gentle. Now, with intra-articular injections of steroid and local anesthetic, this is an extremely useful tool, both in the diagnosis and the treatment of frozen shoulders. A randomized study treatment showed that it was the most marked benefit with steroids injected into the shoulder joint. So we stress that there are two parts of the shoulder joint, two cavities, the bursa and the joint cavity. And what separates them is the rotator cuff and the capsule. So there are two components and therefore two things that can be injected, the subacromial bursal injection or an intra-articular injection. Now, for some reason, almost always when a shoulder ultrasound guided injection is requested, it's into the bursa and not the joint. But if it's a capsulitis, the first injection you have to perform is an intra-articular injection. That is in the glenohumeral joint, an intra-articular injection. And only if that fails do you try subacromial bursal injections if we think it's a capsulitis. Now, the philosophy of a cortisone injection is that the pain has a natural history of worsening over time. Untreated, the worst pain without injection can be at this level. However, if injections are started early and repeated as necessary, then the worst pain the patient endures may be a fraction of what they would have endured without appropriate treatment. So the treatment with cortisone injections, studies have shown that 4 injections given with increasing intervals during an 8-week period were better than no treatment, but we accept that in the long term it's no different. The natural healing takes place independent of the treatment or not, but it's a matter of just controlling the pain, which can be severe. As we stated, a woman in middle age, in her 50s, can sustain pain that can be severe and intolerable for months, if not years. Now, when it comes to intra-articular steroids, a randomized control trial in 2020 demonstrated hydrodilation offered no additional benefit than just a standard glenohumeral joint cortisone injections. So I'd recommend that hydrodilatations are not indicated. Now, so what we do in what we call the one-stop shoulder clinic that discussed at the beginning, well, it's designed to provide a comprehensive assessment, diagnosis, and treatment for patients, hopefully in a single visit. And these clinics aim to streamline the patient's journey. Just for example, what we do in Southern Southern Orthopedics. This is an example of a patient who presents with shoulder pain. He goes to the GP, who requests all the appropriate investigations, and the patient goes back to the GP. Ultrasound demonstrates nothing. So try cortisone injections, goes back to the GP. Maybe it didn't help because it's usually put in the bursa. Off to the specialist. Specialist orders an MRI. Patient goes back to specialist. And only then can the specialist start to predict appropriate management, be it needing surgery, physiotherapy, or steroid injections. So ultimately, it may be 9 trips before the patient gets on top of things. Now in Southern Orthopedics, we try and do it differently. So the patient goes to the GP orders some tests and refers to the specialist, myself. And what we do at that consultation is we talk to the patient about what we think the condition is. We do ultrasounds at the time. So therefore, we can discuss with the patient at the initial consultation whether we need to try cortisone injection. And if we do, we can perform it at the initial consultation, or whether they need to be sent to physiotherapy, whether further investigations are required, such as MRI, or whether it's something else and they need an operation. So hopefully we can nail it in 3 trips. So capsulitis, hopefully with the Southern Orthopedics Clinic, we can nail it in 3 total trips for the patient. Now, what about the procedure of an arthroscopic capsule release? This is where we release the tight tissues and it dramatically reduces the pain and stiffness very quickly. And what we do is we remove the inflammatory tissues and free up the capsule, which hopefully will provide rapid recovery in the stiffness. So it dramatically speeds up recovery of the movement and the pain. And ideally, we perform this when the patient has failed to respond to non-operative measures, so the inflammation is settled, but the capsule's contracted, causing severe stiffness. So now to summarize this condition, what's the differential diagnosis of a primary capsulitis? As we talked about, the most common is rotator cuff tears. It can be shoulder arthritis, labral tears and instability, bursitis, or it can be referred from the neck, cervical radiculopathy. You can have conditions of tendonitis such as calcific tendonitis. The trauma can cause shoulder fractures, and you can get post-traumatic stiffness, be it from an injury or from surgery. So in the case that we said we'd first discuss, the AC is a 52-year-old diabetic with gradual onset, progressive loss of movement, range of motion. What information would you collect from the history, the differential diagnosis, the management plan? When would you refer? How would you manage the situation if you had no red flags? What are the red flags? Would prompt a referral, and what emergencies would present in this manner? The hint in her is that she's got diabetes, so it's not a classic frozen shoulder. So in terms of learning outcomes, I hope we've explained that what a true frozen shoulder is, a primary capsulitis versus a secondary capsulitis, and how it's so different. Understanding the assessment and the management in terms of the history, the examination, and the investigations. Well, I hope this has helped you managing patients with a stiff shoulder. I'd like to thank you very much. And if you have any questions, you can always go on to my website, so.com.au, or email me at mhaber@so.com.au or markdhaber@gmail.com. Thank you very much for listening to this talk.